Among the different checkpoint inhibitors that I'm alluding to one way or the other here, the first that really made it to an FDA approval is Nivolumab. Nivolumab is an anti-PD-1 that, if anything, was approved based on a phase 2 data, which is something that came rather from the left field for us in HCC, an approval based on a phase 2 trial. And this was based on the fact that the trial that looked into Nivolumab in patients with advanced HCC that have failed prior therapy, for example, sorafenib or what have we, led to a impactful response rate. And that's really where the story was. If anything, the response rate on the average between the first-time takers or patients who have progressed on prior sorafenib or any other therapy, on the average probably come altogether about 20%. 1 in 5 patients to respond to therapy, this is all news to HCC. And I would say that the agency, if anything, wisely and appropriately so, did provide a approval for the Nivolumab on that data, with the intense understanding, though, that the oncoming trial of Nivolumab in first-line setting versus sorafenib, which is called Checkmate 459, if it is to be positive, then this will allow Nivolumab to get the full approval. Checkpoint inhibitors or immunotherapy is a subject in all circles in our lives. And in other words, it's not surprising that for all of us that patients will come and say, what about immunotherapy? And as such, there is so much of a anticipation and so much excitement about the subject, and understandably so because of the great results that we're having with it. And for that reason, technically, every patient could be eligible for that therapy. Nonetheless, the expectation that ultimately, despite that excitement, we have to go by, number one, the rules and regulations, who is eligible for that therapy, and number two, of course, who is really can tolerate that therapy. In regard to the first aspect, please do remember that checkpoint inhibitors are not yet approved for treatment as a first-line treatment. Patients should have been receiving prior therapy like on a tyrosine kinase inhibitors to be allowed to get the Nivolumab, which is the sole checkpoint inhibitors that's approved at this point in time. On the other hand, even in that setup, if there is a certain concern about the immune aspects that the patient has in their system that could probably cause a certain concern about giving the Nivolumab or any other checkpoint inhibitors, this has to be put in mind. And this is only as an example, patients with inactive hepatitis B, for example, that is not necessarily under treatment, coming along with the hepatitis C, and that's really creating a certain rather highly inflamed situation in the liver, might be somebody who got to be treated for that purpose before we consider checkpoint inhibitors for them.